Welcome to Weekly Neurology Deep Dive. This podcast is for educational purposes only and has no commercial affiliations. Today we'll be giving you an overview of a recent research paper. But remember to dive into the full paper for a complete understanding. This is just your cheat sheet for staying up to date in neurology.
That's right.
We'll be highlighting the key takeaways relevant to your clinical practice.
Exactly.
This week's paper tackles Intra-arterial Tenecteplase for posterior circulation stroke. Specifically, we're looking at the Attention-IA trial, a multi-center randomized controlled trial published just this month.
This study is particularly relevant for neurologists encountering posterior circulation strokes, like those affecting the basilar artery, in their practice.
These strokes can have serious consequences. For patients, even with successful clot removal, many patients still face disability or even death. So researchers are looking for ways to improve outcomes. That's where this trial comes in. The Attention-IA trial enrolled 208 patients in China who had experienced a stroke due to a clot in either the vertebral artery, the basilar artery, or the P1 segment of the posterior cerebral artery.
The key here is that all these patients had already undergone a successful clot removal procedure.
Successful meaning they achieved at least 50% reperfusion.
Right.
Measured using the extended thrombolysis and cerebral infarction scale, or EDSI.
That's right.
So they had the initial clot removed. What happened next?
The researchers randomly divided the patients into two groups. Half received an intra-arterial infusion of tenecteplase, a clot-busting drug, while the other half received standard care, without this additional treatment.
The big question is, did that extra step with tenecteplase lead to better outcomes for patients 90 days after their stroke? What difference did it make 3 months down the line?
The study's primary outcome was freedom from disability, which they measured using the modified Rankin scale. A score of 0 or 1 on this scale means no significant disability.
Did the tenecteplase group have a higher percentage of patients with a score of 0 or 1?
Unfortunately, no. There was no statistically significant difference between the two groups. 34.6% of patients in the tenecteplase group achieved a modified Rankin scale score of 0 or 1 at 90 days, compared to 26% in the control group.
So the additional tenecteplase didn't statistically improve the chances of being disability-free. What about mortality? Any difference in death rates? Were there any differences in mortality rates between the two groups?
No, the study found no significant difference in death rates.
So no clear benefit on those two key measures. What about the safety profile? Was the tenecteplase group more likely to have complications?
They did observe a numerically higher risk of symptomatic intracranial hemorrhage or bleeding in the brain in the tenecteplase group, 8.3% versus 3.1% in the control group. However, this difference was not statistically significant.
An important point to remember. It's a signal worth noting, but not statistically conclusive.
Right.
Did the study look at any other outcomes for these patients?
Yes, they looked at functional independence, defined as a modified Rankin scale score of 0-2, meaning the patient can function independently. The difference between the groups narrowed here. 40.4% of the control group and 38.5% of the tenecteplase group achieved this at 90 days.
A potential signal, but again, not statistically significant.
Right.
Did tenecteplase affect the patency of the arteries? After the initial procedure?
They examined that as well. 90% of the tenecteplase group and 91.4% of the control group had a patent or open artery at 24 to 72 hours. No real difference there.
They also conducted some subgroup analyses. Right. What did those reveal?
In the subgroup analysis, they found that patients with less severe strokes at the outset, those with NIHSS scores between 6 and 19, might have seen a greater benefit from tenecteplase.
So there's a possibility that tenecteplase might be more beneficial for patients who weren't as severely affected by the stroke initially.
That's the suggestion. But this study wasn't designed to definitively answer that question. Further research is needed.
How does this study compare to other research on using clot-busting drugs after clot removal?
That's where things get interesting. The CHOICE trial, focusing on anterior circulation strokes, did show a positive effect of using the clot-busting drug alteplase after clot removal.
Different results depending on the location of the stroke. Why might that be?
It raises important questions. Variations in stroke type, clot composition, or even specific treatment protocols could contribute to these different outcomes. Further research is needed to investigate these factors.
Before we conclude, are there any limitations of the Attention-IA trial that neurologists should consider?
There are a few. This trial was conducted in China, so caution is warranted in applying these findings to other populations. Stroke causes and characteristics can vary, and treatments may have different effects. in different populations.
So we can't assume a one-size-fits-all approach to stroke treatment.
Exactly.
Additionally, the study wasn't large enough to definitively rule out smaller but potentially meaningful benefits of tenecteplase, meaning further research with a larger sample size is necessary.
Precisely. It's not a definitive answer. Against tenecteplase, just a call for more data.
This deep dive has certainly given us a lot to think about. For neurologists on the front lines, what's the bottom line? From the Attention IA trial, what should they take away? From this research, what are the key takeaways from this study?
Yeah.
For neurologists,
The main takeaway is that adding intra-arterial tenecteplase after successful clot removal in posterior circulation stroke doesn't demonstrate a clear benefit for all patients. There's no significant improvement in disability-free outcomes or mortality rates, however. There's a potential benefit for specific subgroups, such as those with less severe initial strokes, which warrants further exploration.
So it's not a universal recommendation, but it's something to consider based on individual patient characteristics.
Precisely. And as always, carefully weigh the potential risks, such as intracranial hemorrhage, when making treatment decisions.
This study also underscores the need for research, specifically focused on posterior circulation stroke. We can't generalize findings from anterior circulation strokes.
Absolutely. They're distinct entities with unique characteristics. Dedicated research is necessary to guide our treatment strategies for posterior circulation strokes.
This deep dive has certainly sparked a lot of questions. The potential benefit for certain patients, the difference in findings between anterior and posterior circulation strokes. It's all very intriguing. What's the next big question we need researchers to address?
One fascinating avenue is exploring the role of clot composition in treatment response. Clots vary in their makeup, and this might influence how they respond to clot-busting drugs like tenecteplase. Could we personalize treatment based on clot characteristics? It's a frontier worth exploring.
Personalizing stroke care based on the very nature of the clot, that's precision medicine at its best. It highlights the importance of staying curious and probing even seemingly negative results. You never know what new avenues they might reveal.
Indeed. This study, while not showing a sweeping benefit, pushes our knowledge forward and opens up new avenues for investigation.
That's what Weekly Neurology Deep Dive is all about, keeping you informed about the latest research and prompting those thought-provoking questions that can shape your clinical practice. We'll be back next week with another deep dive into the world of neurology. Until then, keep those brains engaged.